Hi everybody, I'm Dr. Deed Harrison, and we're ready for this week's CBP Nonprofit Research Video Review. Hopefully you've been watching our series. We're up to video number 28. What we've been doing, just as a brief introduction, is we're going through each one of our CBP Nonprofit peer-reviewed research presentations. So keep in mind, I'm not just picking a study out of nowhere and going through it. These are actually our formal publications in CBP Nonprofit. Now, many of these have a patient relevance as well as a doctor relevance, and some of these studies have only a doctor relevance. Today, we're going to go through one that has both doctor and patient relevance. We're going to go through another one of our published case studies on chiropractic biophysics technique treatment protocols in a patient with actually somewhat of a complex disorder and injury. We're going to go through a case with Syringomyelia, and I'll tell you what that is as we go through the case. First and foremost, let me read you the title of the paper and then acknowledge the collaborating authors. Conservative treatment of a patient with Syringomyelia using chiropractic biophysics or CBP technique protocols by my good friend, CBP instructor, Dr. Jason Haas, myself, Dr. Deed Harrison, my late father, who's now deceased as of 2011, Donald Harrison, and then Dr. Brian Beimers. Okay? These are the collaborating authors. The first and the last are actually the student interns at the time this paper was presented and then submitted for review and then formally published. So Dr. Jason Haas and Dr. Brian Beimers were actually students at Life West Chiropractic College. Since this time, they've graduated. Of course, this was many years ago. This was published in JMPT 2005, volume 28, online, page 452 through 57. Now, we've got a history in this case of a 41-year-old male who had a traumatic injury. He fell off a ladder when he was climbing up on a roof, fell off a ladder from 9 feet and landed on the back of the head and the upper thoracic or upper back. Now, quite frankly, he's lucky that this is the only thing that he got, if you want to call that lucky. Obviously, many people will die from this, be in a coma, etc. From the fall, when you fall on the back of your head forcefully, it causes a forceful flexion or forward bending of the head and neck. That can stretch the spinal cord rapidly, and then the forces are not allowed to dissipate. They're all acting on the spinal cord, and you get a cord impact and insult as a result. So the cord stretches and then is forced up against the posterior vertebral body or the anterior wall of the spinal canal. That impact can create localized internal shear, both cross-sectional and longitudinal, and that can tear some of the internal tracts or neurons of the spinal cord tissue itself. What happens then is it sets the stage for alterations in fluid force and fluid pressure, so we get a change in fluid dynamics, and these microscopic tears can turn into a large internal cyst or what's called a syringomyelia. Now, not always are syrinxes traumatically induced. There's other causes. In this case, though, the syrinx was stated to be traumatically induced. Okay, the patient started experiencing severe pain, neurologic deficits, and the patient was seen at the Mayo Clinic. At the Mayo Clinic, they did an upper cervical, specifically skull atlas decompression surgery. What they do is they take off part of the posterior lateral bone of the upper neck, and it takes the pressure off the spinal cord, and in theory will, change the fluid pressure, fluid dynamics. In many cases, they do quite well, but in some cases, that doesn't solve the problem. We're going to discuss a case that actually failed to truly recover after this decompression surgery that was performed on him. So in 1995, the patient underwent skull atlas decompression surgery at the Mayo Clinic. It improved him temporarily. However, for 9 years, he continued to suffer. So 9 years later, in the early 2000s, he presents to Life Chiropractic College West in California in the Bay Area. Now, Life West is where Dr. Jason Haas and Dr. Beimers went to chiropractic college. It's also where I went to chiropractic college. It's my alma mater, if you will. So this is a nice intern case. Patient presents to a student outpatient clinic following this injury and surgical procedure. Now, at the time of his initial examination at Life West, here's what he presents with. He's got intractable pain. The pain is an 8 out of 10. That's severe pain. Okay. Now, at this time, it wasn't popular to do disability indices as standard of care. Later, it became popularized. So we don't have true disability questionnaires on this case, but we do have proper exam findings that corroborate what's happening. So pain 8 out of 10. The patient is taking multiple medications for this and has been. He's taken many medications. If you look, many of these are not so good for you, specifically OxyContin. You know, that has high addictive properties, etc. Now, it will help people with their severe pain and their neurologic problems, etc. This is what he's on, okay? Now, multiple positive exam findings were found. I'm just going to highlight the most significant ones. Radiating pain down into the right leg and foot with a positive Valsalva, meaning a bearing down motion and effort produces increased leg pain and foot pain. This is indicative of a space-occupying lesion like a disc herniation or pressure on the spinal cord, even in the upper neck. You have to remember the leg tracts, fasciculus gracilis, are deep in the cord. If I have a syrinx there, that can put pressure on those leg tracts as well. It doesn't necessarily mean that he has a disc herniation in his low back simply because he's feeling leg pain and low back pain as a result of the Valsalva maneuver. Positive Kemp's maneuver also produces pain down the right leg. That means when we go backwards and bend to one side, I elicit a little bit of compression and I get pain. So there might be a space-occupying lesion like a mild to moderate disc herniation in the low back. There's loss of vibration in the right upper extremity, that's the right arm, and the left lower extremity. There's a positive straight leg raise, meaning when we raise the right leg up in the air with the patient on their back, we get not just tightness or back pain, we actually get radiating leg pain. This is indicative of some kind of pressure or adhesions in the spinal cord. It could be a disc in the low back, but it also could be coming from the cervical spine syrinx or fluid-filled cavity that's like a cyst in your spinal cord. Also, multiple weak muscles in the cervical and lumbar regions. He didn't have full strength. He could perform range of motion, but could not adequately resist effort and apply movement under resistive load. Okay. Lastly, severe splinting and spasm throughout the cervical spine and thoracic spine, as you would expect in a case like this. So here's the MRI that was obtained on the patient, and what it shows is, if you look carefully here, you see a little bit of a bright signal intensity right here, roughly at the C3 and the C4 vertebral level. That indicates that there's fluid inside the spinal cord. That's the syrinx. You're not supposed to have a bright signal intensity show up inside the spinal cord. That means there's fluid in there that shouldn't be in there. That's a syrinx. Now, you have to realize the MRI is obtained with the patient on their back laying down, and sometimes they put a little cervical roll underneath the neck when they do this, so like a cushion under the neck for some support. So we don't really truly see what the actual cervical curve looks like. So what we do is we take an x-ray. Now the patient is standing up for the x-ray. Here's the x-ray of the same patient. Here's the MRI. You can see they're different. Which one do you trust? Well, you trust the upright, weight-bearing under gravity, how you look. You don't trust one laying on your back with an artificial support under your neck. That's not really what you look like, okay? Now, the reality of it is this person has a mild cervical kyphosis and significant anterior head translation. So this point right here, this comes up from the lower neck, C7 vertebra, posterior inferior body corner of C7. We draw a vertical line up and we go over to C2, the posterior superior body corner of C2. Those 2 points need to be in vertical alignment in idealized upright stance. This patient has 38 millimeters of anterior head translation. That's 1.5 inches forward. Additionally, the cervical curve is kyphotic in the mid-cervical region. This is not a normal curve. I'll talk to you about the consequences of this at the end of the paper. What I want to go through is talk to you about what was done with this patient case by the student interns. CBP treatment protocol was performed. Now, we didn't have postural photographs, but the intern records show the following postures of the patient, okay? And then I'm showing you the mirror image adjustments that were performed. So let's look at figure A here. A, the patient's lying on their stomach. There's a block underneath the pelvis. What does that block do? Well, the block shifts the pelvis or hips backwards or posterior relative to the feet and the legs. What that means is the opposite was found when the patient was standing up. In other words, the pelvis was shifted forward into anterior translation when the person stands. Many people have this posture. It can be from wearing high heels. It can be from weakening of the abdominal and support structures like not just the rectus abdominis, but the transverse abdominis, right? These are very important stabilization muscles. It can be a weakening or an inhibition of some of the anterior pelvic muscles, like the psoas and maybe some of the thigh muscles. The reality of it is, who knows how it really got there? We find it, we need to fix it, okay? So we're showing you the adjustments for it. The pelvis is forward. Also, what we're doing is shifting the rib cage anterior relative to the pelvis. What that means, now we've got the mouth showing up, we've got a block under the pelvis, the block translates the pelvis backwards, the block also translates the rib cage forward, okay? So when I translate the rib cage forward, it's shifting the rib cage anterior relative to the pelvis. The reality of it is that means that the person had a posterior translation of the rib cage relative to the pelvis or backward shift of the rib cage when they stand up. Now that can put a lot of load on the low back tissues, and it can also, put load on the disc, and that can exacerbate signs and symptoms of low back and leg pain. Several research projects have been done on that very issue, that translations of the trunk load the spine muscles and load the spine tissues like the disc. I personally have done 2 of those papers. We'll go through those at a later time under this video series. Okay, so that's adjustment A for the thorax and the pelvis. The other thing that's happening here is the head is being shifted backwards or posterior, as well as creating some mild extension or backwards bending. What are we trying to do with that position? Well, we're trying to correct that forward head translation and the loss of the cervical curve. Now B is nothing more than A flipped on the other side. So we take a person, we'll put them on their stomach, and then we'll turn them over and put them on their back, and we're going to accomplish the same thing. So the person is on their back now, the head is translated backwards and extended, the rib cage is being translated forward, there's a block underneath the rib cage to achieve that. The pelvis is shifted backwards relative to the feet and the legs. So A and B are the same type of corrective concept, trying to do a full spine side view mirror image adjustment. And then C, what is C? Well, C is the person's lying on their left side and the head and neck are being shifted towards the patient's left. We're trying to create a lateral shift or a lateral head translation. What does that mean? Well, it means that when we looked at the person's posture, their head was shifted linearly, stuck over in right head translation. So we're trying to shift it the other way. Okay, head translations can create considerable pain and dysfunction in people's neck. It will change the pressures on the spinal cord and the discs. It'll change the pressure on the muscles. It can cause pain. It can cause dysfunction. It can cause altered range of motion. Just translate your head over to one side and hold it there and see how it feels, right? I mean, this is what the patient's going through. And then D. D is the person on their stomach laying neutral, but we're turning the feet and the legs towards the left side. So you can see that we have an extra set of hands here. We're rotating the feet to the left. Well, what that does, if you follow the chain all the way up, this hip acetabulum is externally rotated on the left. This hip acetabulum on the right is internally rotated. So what we're doing is we're trying to create a pelvic rotation, okay? So we are creating in this case, a right posterior pelvic rotation by turning the feet and the legs to the left. What does that mean? Well, that means when he was standing, the patient actually had a left posterior pelvic rotation. Okay, some of you may pick that up real fast. Others might need to, repeat this statement and watch the video and do it on yourself to feel what that is actually doing. It's a pelvic rotation adjustment. Now, exercise. Full spine sagittal plane exercises were performed. This is one that matches the adjustment that you just saw. The patient stands, the feet are out in front of a wall, the butt goes up against the wall or a beam, and then I put a block behind the rib cage and shoulders, either in the mid to upper rib cage. What that does, it creates the two translations of the thoracic spine and the pelvis. Then the block also allows the head and neck to be maneuvered into translation backwards and extension. So this is the mirror image exercise that was performed with the patient every time they came in. Okay, additionally, cervical spine traction was performed in two types of procedures or using two types of devices. The first device is a seated or standing when the patient's capable of doing this. This is called the cervical remodeling collar from Myers. Now, Myers is, if you're a chiropractor, it is Dr. Don Meyer from Circular Traction. Circular Traction has many devices to achieve proper spinal correction and rehabilitation in different types of spine configurations. This is one such device that's really good when a patient has forward head translation and loss of the cervical curve. So what's being done here is there's a fulcrum in the mid-cervical spine, and then the head and neck are being pulled backwards into translation backwards with some slight extension. Now, this particular device is started with 1 to 3 minutes, and then we progress to where the person can do up to 10 minutes on this device. You can do it seated, or you can do it standing and even walk on a treadmill at a real slow pace. But keep in mind, we have to do this under supervision initially to make sure it's safe for the patient if they're going to be on a treadmill walking. And we would typically use a treadmill that has bars so the patient can hold on to. Now, then the more aggressive, and I say aggressive not to scare you or frighten you or deter you from doing this. The reality of it is a more aggressive type of traction that we need to slowly progress patients into. It's very effective when we select the patients correctly for this. This is called compression extension two-way traction. This is very similar to what's shown in B, except I've got a much more extreme position of the person's head and neck. This way I can stretch the tissues to their limit and physically load the spine into a proper cervical curvature. Now, previously in these video presentations, I went through our non-randomized clinical control trial on this. We know it's very effective at correcting the cervical curve and at improving chronic neck pain. So we are doing this under supervision in the Life West outpatient clinic. We are going to pull in the lower cervical spine with a load, with weight, and then pull the head and neck back over this. Now keep in mind, some people might see this and decide to do this at home. Don't do that. You don't know if you're a candidate for it. You don't understand the indications and contraindications for this. This needs to be done under a professionally trained doctor's supervision. Now, the people that are trained in doing this are CBP chiropractors that are trained and certified in the technique. We go through this type of traction in a 12-hour seminar, and we do hands-on training of this, and we go through cases, okay? And we go through the evidence, etc. So this is not something that you just go and build on your own and do it to yourself because you saw a video. Don't do that. There are indications and contraindications for this type of traction. We start with 1 minute and we progress our way, in this case, up to 10 to 20 minutes. That's my goal, 10 to 20 minutes. Okay, now, the patient was seen for a course of 3 weeks. 3 weeks at the Life West outpatient clinic. 26 visits were applied to the patient over 3 weeks. At the end of that 3 weeks, a re-examination was performed. I'm not going to show you those re-examination results because they're approximately the same as the 1-year follow-up. The beauty of this case, the reason I think it was properly accepted for publication, is because we didn't just present short-term treatment outcomes after 3 weeks of care. We presented what happened after we stopped care for those 3 weeks and followed the patient for a year with no actual care. So we've got a true 1-year follow-up on this case. Keep in mind, he was severely disabled and had severe pain for 9 years following the surgery. 3 weeks later, he's dramatically improved after chiropractic care with CBP Chiropractic at Life West Chiropractic College. Then we have a 1-year follow-up. Here's what we identified at the 1-year follow-up. His pain is now a 4 out of 10. Does he have pain? Yes, he still has pain. However, it's over 50, or it's 50% better, right? It was an 8 out of 10. Sorry, I was thinking it was 9. It was 8 out of 10, so we're 50% better. Okay, keep in mind he hasn't been doing anything. So he's a 4 out of 10, which is now considered mild to moderate type of pain and not severe pain. Way, way better, right? Way better. He can now perform and do activities of daily living. When you read the paper, you'll see that. Only lumbar flexion forward produced any type of low back pain. His leg pain was gone. He did not have a positive Valsalva. He did not have a true positive Kemp for leg pain, right? He didn't have a positive straight leg raise for pain or for leg pain. He had it for localized pain in the low back. So all these findings show dramatic improvement. And then the biggest thing is there is no more altered vibratory sensation in the upper extremity on one side and the lower extremity on the other side. These are great improvements, okay? So only mild positive orthopedic tests now for simple pain production, not for true, radiating pain and no neurologic deficits. This is a great outcome. Realize it was achieved in 26 sessions over the course of 3 weeks, and now it's maintained at 1-year follow-up. Perhaps one of the most exciting parts of the paper is that the patient was able to self-terminate some of his medication and then also medically supervise, reduce the other medications. Right? Some of these you need to be under direct medical supervision when you go and taper these medications down. There are some pretty dramatic side effects and consequences in people when you start, just dropping cold turkey from these types of narcotic medications. So let's keep that in mind. This is one of, I think, every intellectually honest doctors out there. And I think it's one of the patient's goals out there too. They don't want to be addicted to pain medication. The job is to see if we can teach the person how to self-manage and then guide them towards reduction of their required pain medications. Now I say doctors as loose categories. Chiropractors can't do that. We're not licensed to consult and guide and provide medications. But I can tell you that the doctors that I've talked to, the medical doctors, they don't want to see their patients on narcotics for the rest of their life. That's not the goal. The goal is to use those things to manage a crisis situation and then to slowly wean and taper these people off if we can. That's the type of provider that we want to seek as a patient. And it's the same thing with chiropractors. We want to teach a person how to manage their condition once we get correction, right? And obviously it appears that this was done with this case. He probably followed through with some of his home care on his own, did his exercises in order to maintain this improvement at 1 year. So you follow this. This is an incredible case if you follow through this. 3 weeks, 26 treatments, improved a condition that was there for 9 years, even after decompression surgery at the Mayo Clinic. So here is the initial x-ray. Here is the 1-year follow-up x-ray. You can see the 38 millimeters is now down to 15 millimeters. That's a big improvement. This 15 millimeters is now what we find in the average asymptomatic person in the population. So getting somebody down to around 15 millimeters is actually a great goal. Also, the cervical curve, dramatic improvement. It's now 30 degrees and that mid-cervical kyphosis is gone. This neck curve, for all practical purposes, is now normalized. Does the person still have pain? Yes, the person still has pain. Maybe there's other reasons for it. Syrinxes don't just go away. He likely still has the syrinx in there We don't know because a follow-up MRI was not wanted by the patient. The patient did not want to go in and get a second MRI. The patient actually told the chiropractor that was doing the follow-up examination that he was tired of going to doctors. He was tired of it. He was tired of the surgery. He was tired of the medications. That was what was verbalized by the patient. So the patient didn't want to go get a second MRI, right? Can't blame him. So we don't know what the syrinx looks like. We assume it's still there. However, the pressure has been changed in the central nervous system. The pressure dynamics have been changed due to the correction of the spine. That's what we will discuss next. The reality of it is this. When you lose your cervical curve or you alter posture, it puts longitudinal stretch called tension load on the neural elements, the spinal cord and nerve roots. That tension increases the internal, called the intramedullary pressure inside the spinal cord. It's a fluid-filled system, okay? It behaves like a fluid dynamic viscoelastic structure. Okay, now what happens is when you increase that intramedullary pressure, you can impair the exchange of oxygen and nutrients to and from the core. You will also change the pressure dynamics such that that syrinx might actually slowly expand. Due to the tensile loads, we have some shearing going on around that syrinx. That can slowly progress. That's when you have a flexed neck. When you put a cervical curve in or extension, that takes that longitudinal pressure off the system and it shortens the spinal cord. So instead of being under tension, it's now at a shorter length, okay? Is it like totally relaxed? No, it still has some load on it, but it's not under this direct, dramatic longitudinal tension like a cervical kyphosis in the mid-cervical spine would be. So the theory is that changing the spine from kyphotic and translated forward to a lordosis has changed the pressure dynamics acting on the spinal cord and thus the syrinx itself, okay? There is research and evidence on this. Here's a picture I'd like you to look at. This comes from a famous neurosurgical textbook written by Alf Bragg. This is in the 1960, okay? So 1960. What you're seeing here is the brainstem and what's called the cerebellum. This is the front of the skull. The face would be up here. This is the back of the skull, okay? This is the lower portion of your skull where the spinal cord and brainstem exit out. That's called the foramen magnum. This is the top of the neck. That's called C1. That's the anterior part of C1. That's the posterior part. So you're looking at a cross-sectional slice through somebody's head and neck. So you slice them and you take the left side and you throw it away and you're looking in at the right side. Sorry to be graphic, but that's what's happening. So you got the brainstem and spinal cord. When you don't have your neck curve, what's happening, these arrows are showing longitudinal tension, linear load acting on this structure. Conversely, when you put a cervical curve in, that relaxes and shortens the system. The arrows are coming down. So you're now taking longitudinal stress and strain off the neural elements. This was known as early as 1960 and likely even earlier, okay? So the total longitudinal strain means deformation, so change in shape or size. The total change in the stretch is 7.5 centimeters. That's from top to bottom. Most of that occurs in the upper neck of interest, okay? The cervical cord has a pretty large strain itself, and that's what we're interested in here. Up to 3 centimeters strain or deformation in the cervical cord, and the mid and upper cervical cord would likely be responsible for most. This is the microscopic view, so you can see what's happening at the microscopic cellular level. This, over here on the right, is the same type of concept of this image on the right. There's a cervical curve in there. What you see is the neural elements, the neurons themselves. At the microscopic level, you can see they're slackened. You can see they're wavy. What that is, it's kind of like a rubber band folding on itself, right? So there's slack in this system. Over here, when you lose the cervical curve, you've got forward head translation and a kyphotic neck. Look what happens to these neuron cells themselves, or the neural elements. You can see all the slack is taken up and they're under direct longitudinal stretch and tension. That raises the internal pressure that creates shearing front to back, left to right, circumferential, and it also creates longitudinal shearing. If you had an injury to the inside of the cord, that's going to cause that fluid sac to develop over time. This is the theory of pressure dynamics and how they either exacerbate or are causative factors in forming a syrinx or spinal cord cyst, Syringomyelia. Okay? Again, it's science, it's not made up stuff. I want you to know that this is direct science. This is not just stuff that I'm just putting together off the top of my head. I've read these papers and books. They exist in the literature. You can look them up. For example, this was a reference in Spine in 1994. Spine is one of the top orthopedic journals in the world. Takibana et al., what they did is they looked at volunteer dogs. Forgive me, obviously they call them mongrel dogs. So if you're an animal lover, I'm sorry, I love animals too, but boy, we can learn a lot when we do some investigations like this. What these Japanese researchers did is they looked at the pressure changes in the cervical spinal cord of dogs when they flexed their head forward versus neutral versus extension. And I'm just going to show you this graph here. This is the flexed neck position. Okay, you can see neutral, extended, and flexed. And this is the internal pressure inside the mid-cervical cord. You can see what has happened when the dogs go from neutral to flexion. It doubles the intramedullary pressure in their spinal cord. Doubles it. Goes up by a factor of 2. What does that do when you have a syrinx? It probably exacerbates it. It probably creates problems. This is the idea. What happens when you take a flexed neck and you put it into neutral? Here's what happens. You go from flexion, increased pressure, to neutral, decreased pressure. This is likely why the patient responded the way they did to corrective care. It's changing and improving the pressure dynamics acting on the spinal cord, right? That's our hypothesis. Can we prove that? No, but there's scientific evidence that corroborates that in the literature, right? It's like, can you prove that X caused Z? Not exactly, but there is a chain of events that occur. You go from X to Y to Z. And so we can put those pieces together and we can say, this is exactly what happened, all right? At least in our clinical hypothesis. That's what a clinician sees. The patient also sees that. The researcher, hey, we want a randomized trial on 100 consecutive patients with syringomyelia that are traumatically induced with a kyphotic neck. Let's randomize one group to, no care or conservative traditional care, and the other group, let's randomize them to corrective care and see what happens, right? Until such time, what we do is we can look at this case, we can say in this case it worked out. You never know, but in this case it made sense. So, case report conclusions. This report describes successful outcomes of subjective and objective findings in a 41-year-old patient with syringomyelia after CBP rehabilitative care. The improvement in the cervical curve is a possible, keyword possible, factor in the patient's improvement. Further studies need to be done to confirm this or refute this. In this case, it seemed like it worked, and the pressure dynamics and the biomechanics of the spinal cord that are known, we know those pressure dynamics and biomechanics, that supports the findings in this case. All right, hopefully you've enjoyed this case. Listen to the message at the end for CBP nonprofit research support and or to find a CBP trained chiropractor if you're a patient out there. Until next week, thank you for your time and your attention. If you like this information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy to use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP Nonprofit will get 0.5% of all your purchases, which is a big deal. It adds